Hello and welcome back to season 3 of Level Up Infection Prevention Podcast. I'm Michelle Strange and I'm excited to have you join me as we dive deeper into the nuances of infection prevention and patient safety. And today we're going to be talking about backflow and suctions and some things that I don't think get enough screen time, if you will. I think it's a topic, though, that is so important in creating those safer dental visits. And so I'm thrilled to be joined by Amanda Hill, who brings a wealth of knowledge and I think also practical insights to the table. So welcome, Amanda, to the show.
Thank you for having me, Michelle. And I'm always happy to talk about the grossness of backflow.
Backflow. Okay, so let's start with what are we even talking about? Why does this matter?
So, backflow is when previously suctioned fluids, meaning the patient before, then end up in the next patient's mouth. And that occurs when our patients create more pressure on the suction than is coming from the vacuum. So that means when they have their makeout session with the suction to get out all the fluids from their mouth, or we as clinicians say, okay, close down nice and tight, because we say it. We say it. When we do that, that then puts that patient at risk for backflow. Backflow can also occur when tubing is brought from high, like here's the patient laying down, it's coming down on the patient. So gravity. And backflow can also occur when you're using high volume evacuation with slow volume evacuation at the same time. So if you're going to do that, I'm not going to say don't do that, but I'm going to say if you're going to do that, I want you to make sure you keep it low coming into the patient's mouth. I don't want it to be coming high so that then gravity is working. That's where backflow occurs normally. And that just means that's the patient is then sucking on whatever's downstream in that tubing.
And we've been talking about backflow for a minute.
Oh, this isn't new.
This is not new, but it's a new to so many people in dentistry.
Somebody on Facebook just the other day said, is it so hard for patients to close their mouth on the suction? And I was like, yeah, oh, Michelle, there is a way around this because I got to tell you, having a patient close their mouth on the suction is, for me as a clinician, is convenient.
Yeah. Okay. This is where I think those practical tips come into play because what we're hearing, I think there's multiple layers to this story, right? We have an issue with some of our vacuum pumps being older, not pumping, not pulling enough, which will increase your chances of backflow. We have pumps and vacuum lines not being taken care of very well. That will clog and create, and we could dive into nuances of each one of these.
Yes.
And then we kind of have maybe too many people using HVE at the same time when we weren't built out for that many people. Especially since the pandemic, more hygienists are using high volume. And then we have the position, like you mentioned, it being so much higher. And we have had a habit of saying, close your mouth. And I totally agree with you. It's very convenient. One, you're right. It clears out all the fluid from that patient's mouth. Two, some people just need it because they feel like they're drowning. They have airway issues. It's kiddos. They have a bad taste. There's so many reasons for that. In the event that we do need them to close, what were those solutions you were talking about?
So there are backflow prevention devices that you can use. They have them for both the slow speed, Mr. Thirsty, your suction, and they also have them for your high volume evacuation as well. There's a few different ones on the market. They make ones that are inline backflow preventers. They end up about 3 inches below the suction valve. I don't think I'm a fan of these for a couple of reasons. One is it's 3 inches below the valve. So 3 inches, you still have all that. There's previously suction fluids in that 6 inches because you got the valve, maybe 5 inches, 5 inches for the valve, 3 inches. But my next issue with those built-in ones is because it's a static thing. How do I know when that flapper valve fails? Because it's going to fail at some point because that's just biofilm and grossness and sludge. Right. And so how do I know at what point? It's not like it has a red light, green light. I discourage use of those inline ones. They do make disposable ones. So there's a couple companies on the market that make one that you just put in your suction and it has a little flapper valve. And if a patient closes down, it will not allow that to happen. And so that one-time use only, you throw away. There's another company that makes one that involves not only a flow preventer, but a disposable valve, which it's nice because if we got into the nuances of the suction valves, like, first off, think about trying to actually disinfect that properly, right? With a wipe.
Yeah,
Hard.
we're talking about like the on-off
Yeah,
valve of
on
your
off.
suctions. Yeah.
Yeah. So hard to do. If you read the instructions for use for your valve, it might actually
Mhm.
tell you that you have to reprocess that between every single patient. Or it might say once
At
a
least
day.
at some point.
Yeah, it will have reprocessing instructions. Have you ever tried to take apart one of those? I tried to in my office when I learned all this a few years back. And it was like a gorilla glue of biofilm, Michelle. I couldn't push the thing out. I had to sit in hot water and let it soak. It's like soaking the pan that you burnt something in. You gotta let it soak for
Yeah.
a while, and then you gotta scrub. Anyway, super gross. So there is a company that makes a built-in backflow device with a disposable valve, which is really nice from an infection control standpoint. There's also another company that just recently came out, and I haven't used this yet, but there's an autoclavable
I
backflow.
have it.
You have it?
I have it. I have not used it
Okay.
yet,
Yeah,
but it is
okay.
from Maxell, I believe,
Maxwell.
MAX,
Yeah.
which is a Canadian company. So yes,
Yeah.
I
And so,
have
like, you
it and I'm
take,
gonna try it.
okay, I
Yeah.
can't wait. I can't wait to hear. You like two little pieces, you autoclave the pieces, and the little flapper valve is disposable, but it's only the little flapper valve. So environmentally, what a lovely idea. And it comes in pretty colors, which makes my heart happy because I like
That's
pretty.
true. We love a color coding system.
I really do. So those are some of your options for preventing backflow at the patient. Like that's at the patient level. Then a patient can go ahead, they can have their makeout session with Mr. Thirsty. They can comfortably get the toxic fluids out of their mouth. They're not toxic fluids, by the way. But anyway, patients think so. But to me, Michelle, you know how we talk about hierarchy of controls? We talk about infection control and PPE is the bottom, right? PPE is our last research. I almost feel like that these backflow prevention devices, while crucial, like you should have one, right? And you want to talk about an easy way to market that to patients. Tell them about backflow. They'll be like, oh, yeah, I want that because that's gross, right?
So gross.
If you're not using infection control for marketing. But I feel like those backflow devices are your PPE. That's your bottom. That's your bottom of the pyramid. And doing things like you just talked about, which we can dive into, talking about making sure your vacuum's the right size, making sure you're doing that maintenance so that then that decreases your chance of having backflow and making sure that your lines are clean.
That's actually, I like that analogy because I do talk about the hierarchy of controls quite a bit. So PPE being the least effective, I like that. But then here comes the work practice control, which is the hardest, I think, because that's our behaviors and that's
Right?
telling people not to close their mouth. But then actually taking care of the units are going to be your bigger
Right.
picture here. And you and I have graduated many a year ago. So we've been doing this a minute,
I'm a whole
a few
century now.
decades. I joke I was like the only graduating fetus ever in hygiene. So still very young, but
Yeah.
still been doing it for 25 years.
Yeah. Weird.
But I know, not weird at all though. So I talk about like how I started with a bucket of soapy water
Totally.
and that's how I
Yep.
cleaned my suction lines.
Right. Yep.
And now we know so much more.
And now we know so much more. So we had that bucket of soapy water and where we did the plunge and slurp method. You plunged it in and then you put it at the surface and let it, and then you plunged it back in
Yeah.
again. And when I talk about that, often I use the analogy. Have you ever driven with somebody that's learning to drive stick shift
It's a
car?
great analogy.
And you're like, go, 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 go. That's what's happening because they're trying to figure that is what your vacuum is doing. It is while you're doing that plunge and slurp to your vacuum. It's not good for your vacuum. So first up, it's a lot for your vacuum. It's almost like it's doing a beer bong. You're like, I'm
A
trying.
lot of fluid at one time.
It's a lot. But also what's happening with the plunge and slurp method and the bucket method is that fluid, that solution that you're using to clean your lines, gravity is just holding that solution at the bottom of that line as it goes across. Where you and I know we both really are in favor of an atomizer. So something that you stick your tubing to and it brings up air and the fluid and the solution at the same time. And then it creates this little tornado vortex inside the line. So it's actually leaning all 360 degrees of the line, not causing your vacuum to choke because your vacuum then is getting
Yeah.
that solution and that air at the same time. So, okay, I can do this. I can drink this. And the super bonus, Michelle, is using these atomizers. It's hands free. I could pop it on, let it go, and type up my notes or disinfect my room or do whatever I need to do. I'm not sitting there plunging, slurping,
Yeah.
And many of them actually will stop all by themselves when it has the right amount, like when it's sucked up the right amount of stuff.
Yes. And
Um,
my
yeah,
little ADHD heart loves that
right,
version because I can walk away and finish cleaning my room and
right.
all of the things.
And ideally, you actually want to, after you're done, after it's soaked up the right amount of solution, you actually want to let some air go through your lines for a couple of minutes.
Yes.
You actually want that to happen because you want it to travel all the way to the vacuum, wherever that is. And so this is a great way to be able to do that again and not be like, I don't know, just standing there holding them on or whatever you're doing. And so you can just do that and get more work done. So an atomizer, hands down, get it, hands down. The way to go. I didn't even mean that, but that was, yeah, you should definitely be using an atomizer at minimum daily
Yes.
to clean your line at minimum. And if you had really bloody, you had a super like bloody non-surgical periodontal therapy, you know what I'm talking about, right? You're like, it's a murder scene.
Yeah.
Well, I would highly recommend running it in between patients. Cause again, think about that chance for backflow. I think the CDC says 1 in 4 people experience backflow. Is that what the CDC says?
I think so. And it
Yeah.
makes me want to
So
get a
think about that, particularly if you had something that was a really bloody procedure. Think about what you would want. Would you want to know that was still like inches away from you? Or would you want that to be flushed through? I want that to be flushed through.
yeah. And I went into an office one time and had a cleaning for the first time ever because who does hygienist tea?
Yeah, no,
And
that's just between 24 and 25 with my Montana Jack,
and
right?
honestly, I was like, I know there's so much coffee stain everywhere. I need it off of my teeth. I can't. I've done what I can do here. I need it. And I remember her going, okay, close. And I like just literally took the suction and just went, "Ah, ah, 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 ah." You know, I can close. I was like, I'm like, why does anybody ever let me in anywhere near that? Because I'm like, absolutely not. That's disgusting. Excuse me. Sorry. That was a really ridiculous reaction.
Yeah.
Let me tell
Yeah.
you why. I was like, absolutely not. I would not. It's so icky. You know, the other thing too that I learned along the way here is that when we put all that water, like we have a lot of right angles in our plumbing. And
Yeah.
when we are, and not just in your, like your lines at your dental unit, because that's
Right.
where I thought that's where it started and ended for me. What's
Right.
right here in front of me that I can see? But the reality is there's so much like in the floor, up the
Yeah.
wall, in the ceiling
Yeah.
that we have to manage. And that's not, let me just call the plumber. This is ripping out plumbing to
Oh,
fix
that's
this.
jackhammering up the floor.
And I can't imagine. Talk about not getting a bonus that year, right?
Yeah.
So I what didn't realize that when we put all that water and that fluid through and it hits that right angle, literally all that slush that we are sucking up, right? Just stops there and it like dead ends. And that's where we start to see some of that clogging there, which I thought was, I was like, oh, okay. It's not
And
just
I'm
these
wondering,
things that I touch.
Michelle, like post COVID, when all of a sudden, like we started using HVE, hygienists, we meaning hygienists, because I'd never touched the HVE.
Yeah.
I was always just saliva ejector, right? Then all of a sudden, oh, aerosols. Oh, I didn't know about you guys. Okay. And then we started grabbing the HVE. And when they came in and designed offices, they looked at doc op. They did the math, the suction math. And the suction math looked, okay, doc op, HVE, doc op, HVE, hygiene op. We're only considered half.
Right.
There's so many places I could go with that, but I'm not going to. But and so we were only considered half in the math. And so now that I was using it and Karen
Yeah.
was using it and then Jim was using it in his room, like our vacuum just didn't have the capacity that it needed to have. And so I would encourage anyone if they're replacing their vacuum or they're doing a remodel or maybe building a new office, really do the math for everyone to have the ability to use the HVE. Because if you have more, that's better than having less. Because it's terrible. Early COVID, I would turn on my HVE and Karen would turn on her HVE and our
And it's
standard
like,
cubic feet per minute went down to 1. There was no sucking happening. It was like
yeah.
nothing was going.
Nothing. No, I totally understand that. And I would even say, even back in the day when I used slide ejector, I always knew when someone turned on their HVE in the office
Yeah.
because mine would go down to a gurgle,
Right.
which happened to me recently in an office. And I was begging them to do their daily suction maintenance. And they just were like, it's fine on Thursdays. And it finally got to that gurgle. Like I knew next door when they turned their HVE on, I was like, listen, I'm going to tell y'all right now, this is not just for saliva and fluid. This is aerosol management.
Aerosol.
And I demand proper aerosol
Yeah.
management. And call me a diva, call me what you want, but I'm not breathing in this stuff, please and thank you.
Yeah.
Or do I want the next patient? So we started doing suction line mate. I was like, but don't you want to? Like, it's going to be
Right.
so expensive
And I gotta
to
tell you,
fix this
this is
problem.
doing that maintenance. I know you're like, does it really make a difference?
It
It
does.
really actually does. And coming out of COVID, I had Robbie, he's our rep from Air
Yeah.
Techniques. Robbie from Air Techniques came to my office and we tested the vacuum and we tested the standard cubic feet per minute, the SCFM, and we did the valves and we turned on Karen's and would plummet it and all that stuff. And so I said to Robbie, like, Robbie, crap, do we need a new vacuum? And Robbie's like, hang on, hang on.
Mm,
Let's do a couple things first. And thank goodness, because Robbie only had the benefit from me telling the doc we needed a vacuum. But Robbie's like, so the first thing he said was, okay, are you guys running your suction daily? And I'm like, we run it with a bucket, right? And he's like, daily
or shot.
suction
Yeah.
with the atomizer. So that was one. Number two was we opened up our chairside traps.
Oh, that's another point that we need to get to are the
Oh, they were
traps.
so gross, Michelle. There was no airflow through those traps. They were, oh, he's okay. Every week, you got to change this chair side trap. And in the beginning, you might have to change it more often because you're going to clean extra sludge right in the beginning.
Yeah.
Right? So first, everyday suction. Next, clean those chair side traps at least weekly. And then we walked over to the vacuum and we looked at the canister trap. And he's like, when was the last time this was changed? I don't know.
Well,
And so,
most of the people don't even know they existed.
right?
So never.
Yeah, so we unscrewed this thing and it has a metal wire
Filtering
circle kind of thing in it,
yeah.
like a mesh thing. And you're supposed to see through it and you really couldn't. And so you talk about, so you were losing airflow from the trap, from the chair side trap, right? And then we're losing airflow from the trap in the vacuum. And so we changed that up. For our vacuum, the instructions for you change that monthly. So monthly, we should be unscrewing that and then changing that out and putting a new one. Again, increasing that airflow and making a real big difference. And then the last thing that we did was we changed our tubing, our suction tubing.
Mm.
And our suction tubing, I think, was 30 years old, maybe 40. I have no idea. Literally, when I took off the slow speed tubing, I have a video where I bend it and you can barely even bend the tubing. Because not only is there stuff inside, but our disinfectants on the outside really start to affect that rubberiness.
Yeah, I know exactly what you're talking about.
So I changed out all of our tubing. And per your suggestion, actually, I changed out the HVE tubing to that really lightweight tubing.
Yeah, huge difference. I think you and I have both gotten it from that A-Flex Assist.
A-Flex. Yeah.
And yeah, night and day. It's like clouds and cement blocks.
It is. It is. It's clouds and cement blocks. You pick that thing up, particularly if you're trying to figure out how to incorporate HVE. I think 8 feet of it weighs like, oh, guys, you'd have to Google it. I'm going to get it wrong. 6 ounces. I don't know.
Something crazy light.
So light. So
Yeah.
light. And it's funny because initially I only did the hygiene ops and the assistant, Stacy, she felt our lines and she's, will you do mine too? And so I did and changed hers. And as an assistant, even she was like, oh my God, oh, this is so much better. It's so much nicer. So anyway, we started daily suction, changed our chair side trap weekly, changed the vacuum trap monthly, and changed out the suction tubing. And we went from 5.7 SCFM, standard cubic feet per minute. That's the air and the vacuum that comes through at the same time. Recommended in the US is 7.1. We went all the way from 5.67.
Something,
We went up to 7.3.
Just with little simple changes.
Just those changes. Just doing the proper maintenance.
I would imagine then increases the life of the actual vacuum pump itself, which is another huge investment.
Absolutely. So making those, and those were all easy changes, Michelle. Like that was not a capital investment of anything.
No.
The tubing, I changed myself. We didn't even have to call in a service tech. I did it. You just pull it off and pop some back on.
Oh, yeah.
And
So
it easy.
I agree. And I would also comment that not every single vacuum pump has that filter. You need to go find it though.
Yeah.
Because I've been in there looking like, where is it? And it didn't exist. But certain ones like dry pump versus wet pump, those are different. And so some have them, some don't. So don't be like shocked if you don't see it. However, if you got it, you got to be changing it. Like it's going to make a huge difference for you. Yeah. And then I think the other part of this conversation are the amalgam separators.
Yeah.
Because That also has decreased for a lot of people. The flow, which was something that was mandated back, I think you and I have talked about this before. It started like it was told to us in 2017 and then got mandated, like you have to have this by
Right.
a date. And I think it was like 2020 or
It was
something.
2020. Yeah,
Yeah.
because people were like, "Wait, aren't they gonna extend it because of COVID?" And people were like, "No, you had
You've
enough."
had 3 years.
You knew.
You've
You
had a
knew this
minute.
was coming. This one.
Exactly. So
Yeah.
we do have to have these amalgam separators
Yes.
or some kind of capturing device
Yes. An
for
amalgam capturing
amalgam
device. Yes.
procedures. And you and I have talked about this before as far as how do we manage our amalgam separator and how do we even manage our traps and what are our other solutions?
Yeah, so there's a couple things when it comes to your amalgam separator. One, do not believe your well-intended sales rep who has gotten information and they say information that they're okay.
Mm,
But don't believe your well-intended service or sales rep that says that your amalgam separator, you only have to change that trap once a year.
yeah,
Because just like any trap, you got to check it. And I highly recommend checking it with a UV flashlight. If you stick a UV flashlight to the side of it, you will see actually where the fill line is because it's hard to see.
that's very
And
helpful.
and they fill with prophy paste, they fill with erythritol,
Powder,
they
yeah.
fill with whatever. They fill up fast. And a lot of people are changing those things every 3 to 4 months.
Oh, yeah.
And it really is. And once it's full, it actually starts to bypass the machine. And then you're just sending your mouth wastewater into the world, which is not what we want.
Not okay. Yes. Not
So
okay.
that's your first thing for checking it and making sure. And when you change that trap, for the love of Pete, I want you in full head to toe PPE. Work full. Frankly, I'd like you in a hazmat. I want you to really think hard about that. I want you with your heavy duty gloves that I know you hate, but you are now dealing with something that is toxic.
Yeah.
That's why it can't go downstream. It's toxic. You were taking that thing off and you were breathing. And so I really want you to be careful. If you don't like, some people bring in a service tech to do it. Great. Let the service tech do it. But if you are doing it, I want you in full head to toe PPE. I want you to take that one seriously because that is not safe for you if you're not.
Yeah.
But that being said, any trap, chairside trap, back to the chairside trap that we're changing once a week, any chairside trap that is in an operatory where amalgam is being removed. So if you're removing, maybe you're not placing amalgam, but you're removing old amalgam fillings, that
Mhm.
chairside trap has now become hazardous waste
Yeah.
and must go into your hazardous waste bin. It can't be incinerated. So it's not your sharps. Don't put it in your sharp. Don't put it with your bloody gauze. Like it needs to go in its own little separate. You probably have a bucket.
That's like an amalgam bucket.
Yeah,
Yeah.
an amalgam bucket. And that trap actually needs to go in there because it can't be incinerated because we don't want to incinerate mercury. Now, Michelle, there is a workaround to this. And I got to tell you, there's a lot of people that are getting rid of their amalgam separators because of all the reasons I just said. They fill too
Yeah.
fast. They're toxic to change. You got to deal with the bucket and all that stuff. And there is a handheld amalgam separator, which complies with all the EPA regulations, not a problem. You can register it with your state, easy peasy. And it's really cool because it's a suction tip, but it has a capture device in it. And it actually then filters the amalgam and actually does a better job than your amalgam separator does. And it holds that amalgam for you. And then you just take that handheld amalgam separator and you put it into the recycle box that it comes with, which I did just find out Monday. If you extract teeth with amalgam, you
Yeah.
know how teeth with amalgam have to go in hazardous waste, right?
Yeah.
They can go in your box with your handheld amalgam separator. They can
Ooh,
go with your Captol box. I
that
just
is
did
a
Monday.
helpful little tidbit.
Yeah, just learned that because I was giving an infection control lecture for an office that uses it's called Captol is
Yeah.
the name of the product. But the thing that I love about this product, Michelle, and I know that you like to, you're a little crunchy green, save the earth kind of.
Yeah.
This product is 100% recycled. The whole thing.
Which is amazing.
The
But you
full
don't
thing.
hear about that very
No,
often.
because your amalgam separator filter, that's landfill, baby. That's landfill, mercury hanging out. Bleh. This thing gets completely 100%, all the pieces taken apart, actually gets sent to a couple different places to get completely recycled,
Wow.
which I love that idea. So not only are you capturing more amalgam
Yes.
at the source, so it doesn't have to go, right? Capturing more amalgam at the source, but the entire thing is then being recycled and you are still compliant and you don't have to deal with that darn thing that already pulled out of your suction and made your suction worse. Ditch it.
The other thing too is when we talk about those traps at chairside, we need to be wearing all of our PPE. And we've chatted about this before too, is I think you need to change your trap right after you do that amalgam procedure. Mostly because if I'm rando Michelle coming in on Monday and we're like, it's time to
Right.
change traps, I might not pick through what's in that trap and be like, that's mercury, that's amalgam, and not know and put it in the wrong bin. So I
Yeah.
think it needs to be done right after by somebody who just worked that procedure, knows that
This one.
is in a special team.
Or just use Capdol and you don't have to worry about it at all.
I
Because it never
agree.
made it to your
Yeah.
trap. It got
Yeah.
caught right there. Which
So for anybody that's struggling with their amalgam separator, there is a solution for them. And we know that all of these things combined can increase our risk or less aerosol management and backflow for our patients.
right. And so this is about keeping you safe and keeping your patient safe.
Yeah. Anything else that we miss when we're talking about backflow and patient safety around and our safety around suctions and aerosols and all of that jazz?
I think the last thing that I would throw in there is, and we touched on this a little bit, but I want to reiterate it because I still don't,
Mm.
I don't think we're doing it. Is right after COVID, we hygienists, we brought in HVE, right? We were like, okay, ooh, we got
Hopefully.
right, hopefully. But I got to tell you, if you brought it in, I got to tell you, I think that many of our colleagues ditched it. And there are
Yeah.
a lot of easy ways, I promise you guys, to incorporate HVE that are still ergonomically sound for you. Things like using a Cordy's bracelet, which is a cord management system. So if you're doing handheld high volume evacuation, you can hook the tube in there. Super nice and easy way to do it and take some of the strain off. There's lots of hands-free ones that I love. Isovac is one of my absolute favorites. People love the aerosol assist.
That's the one I use. Yeah.
Okay. My hygienist at my office I was at Monday, she likes one of those suction mirrors. She likes the one by
Oh.
Golden Dent. That's her favorite.
Okay. Yeah. I've seen that one.
Yeah. And that one does actually have enough
Openings to create that 8
openings to be
millimeter.
considered HVE. Yeah. It does a good job.
Yeah.
So still try to incorporate HVE because no matter what, I know COVID's gone, but bird flu's coming, my friends. Something's next. I'm just saying.
Something
I'm
always.
just saying. But even just regular cold and flu. We know that we're not aerosolizing patients' saliva, but we're still, it's all just, there's just stuff, right? There's
They're
still just
generally
stuff.
water lines. They have a lot of hairy
Right.
bacteria in there that
Yes.
cause problems that we know. We know we're aerosolizing. And it's also good to have a good technique too. Using one that where you're close, so you're capturing as much of that aerosol spatter and spray versus it being like, I don't even know where in the mouth, in the room, whatever. So I agree. If you've ditched HVE, I think it is incredibly important for us to get back to it. It is one of those engineering controls that was created for us.
And that's way higher on the pyramid.
Yeah.
It's up here.
And when we don't use it, we are asking our PPE to carry a burden it just never was meant to carry. And so it's too much. We have to have all these other things in place to keep us safe and our patients safe. Amanda, thank you so very much for coming
Thank
on.
you for having me.
I would love
to talk suction.
Right? We're happy to talk about a lot of topics.
I know.
Okay, all the
We're a
time.
little weird. We're a little
We are
weird.
a
like-
little weird.
Yeah.
I would love for you to tell everybody where to find you, where they can learn more, maybe hire you, bring you in for consulting, whatever these days.
Absolutely. I try to make it easy. I'm Amanda Hill RDH. So Amanda Hill RDH on Facebook, on Instagram, on LinkedIn. If you want to email me, it's amandahilldh@gmail.com. And my website is amandahilldh.com.
We love this energy.
I know.
Feel it. Well, thank you so much. And we hope you guys enjoyed this and learned a little something about backflow and your aerosol management with your suctions. And definitely check out Amanda and all of her fun content.
Thanks, Michelle.
Thank you for listening to Season 3 of the Level Up Infection Prevention Podcast. Don't forget to follow or connect with the guest. And while you're at it, follow me on Instagram, Level Up Infection Prevention. And check out levelupip.com for more details on all the digital courses and the Infection Control Coordinator's Guidebook.